Good evening, everyone. So this week's lecture, I thought after basics of keratinization, I should now tackle the disorders of cornification. These are the other Ichthyosiform disorders. And I received multiple requests that this is one of the most difficult to understand chapter from Rooks textbook of dermatology. So I thought, why not try to simplify these disorders? And even this chapter was so tough for me too during my residency, it is still tough now. In fact, reading it again, kind of rekindled that PTSD memories during my residency. So I thought I'll make it a bit simpler to understand. And if you have gone through last week's lecture on keratinization and you know the basic proteins and the basic process which is happening in the background and through which a corneocyte is formed, I think now you are in a better position to understand ichthyosiform disorders because you know a lot about the different proteins which are going to act in this process. And if something goes wrong with a particular protein, what kind of disorder or what kind of clinical features do we expect? Okay, so without much further ado, let's start our discussion on the part one of ichthyosiform disorder, dealing with the common ichthyosis and autosomal recessive congenital ichthyosis. So let's start the part one of ichthyosiform disorders. Now, in ichthyosiform disorders, there is defect in the formation and or function of the cornified envelope. So last week we discussed how a cornified envelope forms and what are the important processes, enzymes and proteins for the formation of cornified envelope. If by any chance this envelope is not properly formed, you have ichthyosiform disorders. Okay, it is an extremely variable phenotype. Why? Because understand that so many different kind of proteins are acting together to form the cornified envelope, and there can be innumerable changes, innumerable mutations in any of these proteins. That is why different mutations, even in the same gene, even in the same protein, can lead to clinically different results. Okay, that is why clinically the disorders can be very variable, but just remember that being ichthyosiform disorders, they are scaly disorder, they are dry skin disorder, they are scales. Scales have to be there, okay? Just remember that. Now, another term that you will hear quite often is MEDOC or Mendelian disorders of cornification. That is nothing but disorders of cornification is ichthyosiform disorder, ichthyosiform disorder. And by Mendelian, we mean that they are genetically linked or genetically transmitted. Okay. So any ichthyosiform disorder genetically transmitted is Mendelian disorders of cornification. Clear? The word cornu from Latin gives rise to cornification or the cornified envelope or corneocytes. And cornu means horn. So the skin becomes as dry and as thickened as a as a horn. Okay. So that is why it is the stratum corneum, the cornified layer, the cornified disorders, the corneocytes. So the words have come from the Latin word cornu, which means horn, because it's like spiky and as dry, as rough as horn. Okay. Let's move forward. Now, let's start first with ichthyosis. The term ichthyosis was given by Willen and comes from the Greek word ichthys, which means fish. Okay, so that is why by ichthyosis we mean it's a scaly fish disease. That's what the transliteration of ichthyosis is. Now, ichthyosis was initially divided into non-syndromic and syndromic. That means in non-syndromic ichthyosis, you have majorly skin involvement in the form of scaly disease, while in syndromic ichthyosis, you have scaly disease as a part of other features involving other organ systems like ears, heart, GI tract, endocrinal abnormalities, craniofacial abnormalities, neurological issues. So then it becomes part of syndromic ichthyosis. Okay, let's move forward. Now, in ichthyotic skin, there is abnormal quantity or quality of scale. That means the scale can be abnormally produced in large numbers, or they are not normal scales, they are dry scales. Okay. Now, this abnormality of scales leads to compromised barrier function. So we all know that skin is required to perform a very important function by acting as a barrier. Okay, barrier against the environment. And because of this defective skin, it's not able to do their function properly. Now there's also altered epidermal cell kinetics. That means epidermal cell movement, isn't it? Kinetics means movement. So the epidermal cell, when it crosses from the basal layer towards the corneal layer, that movement is altered. So you have altered epidermal cell kinetics, and these three problems you will see in an ichthyosic skin. You will see abnormal quality and quantity of scale, you will see a compromised barrier function, and you will see an altered epidermal cell thickness. Now, it leads to two type of hyperkeratosis. By hyperkeratosis means this thickening of the corneal layer, okay? In retention type of hyperkeratosis, there is improper shedding of corneocytes. We all know that when a cell moves from the basal layer to the corneum layer, and eventually the cells will shed off. They will fall off layer by layer, single cell by cell. If this shedding does not take place, okay, if this shedding does not take place, the corneocytes will get accumulated, okay, because they're not able to move freely. Now, when these are accumulated, they are retained, and that is why this is known as retention hyperkeratosis. Okay. While in the other type of hyperkeratosis, which is known as hyperproliferative hyperkeratosis, there is increased production of keratinocytes or corneocytes. Okay. This we typically see in diseases like psoriasis, in which the epidermal cell turnover time is increased to such an extent that a lot of cells are being produced, and that leads to thickening of stratum corneum. So you have two types of hyperkeratosis, retention and hyperproliferative. In retention, the cells are not able to get removed from the skin, while in hyperproliferative, their production is high. So in hyperproliferative, the input is high, while in retention, the output is low. And that leads to accumulation of corneocytes, leading to an ichthyotic skin. Let's move forward. Now, this slide might be perhaps the most important slide of this talk. And this is, I've tried to divide ichthyosis into understandable terms. So if you remember these headings, you'll be easily able to understand what exactly is happening. Okay. As I've told you that ichthyosis has been described, divided into two parts. You have syndromic and the non-syndromic ichthyosis. Okay. Under non-syndromic ichthyosis, you have a subpart known as common ichthyosis. So let me make this again. You have a subclassification of common ichthyosis. Here I put it separate because these are the important ichthyosis that you should understand during residency. Okay. So in non-syndromic ichthyosis, you have common ichthyosis. In common ichthyosis, you have Ichthyosis vulgaris and recessive X-linked ichthyosis or X-linked recessive ichthyosis, XLRI. This is also known as XLRI. Okay. In non-syndromic ichthyosis, apart from Ichthyosis vulgaris and recessive X-linked ichthyosis, you have autosomal recessive congenital ichthyosis, and this is known as ARCI. Okay. These includes the other well-known types of ichthyosis which you should know at residency. The second part is keratinopathic ichthyosis. Now, in keratinopathic ichthyosis, the mutation lies in keratin. So, they are pathologies because of keratin gene. And we all know that keratin mutations can lead to bullous disorders because we have seen that in epidermolysis bullosa. But if the keratin is higher up in the skin, okay, in epidermolysis bullosa, you had problems in keratin 5 and 14. These were the basal keratinocytes, sorry, with basal keratins. But if the problem arises in a keratin higher up, you can have problems in the stratum corneum and leading to ichthyosis, which are known together as keratinopathic ichthyosis. Okay. The third non-syndromic ichthyosis is epidermolytic ichthyosis. Okay. So if you have to divide ichthyosis, you will divide it first into non-syndromic. The non-syndromic will have common ichthyosis, autosomal recessive ichthyosis, keratinopathic ichthyosis, epidermolytic ichthyosis. So this is non-syndromic. Then you will have syndromic. In common ichthyosis, you will have Ichthyosis vulgaris, recessive X-linked ichthyosis. Clear? So with that, In this particular talk, we'll just keep our discussion restricted, okay? Our discussion will include common ichthyosis, XLRI, ARCI, group of disorders. Now, this will be the part 1 of the lecture. And next week, we'll discuss part 2, which has keratinopathic and epidermolytic ichthyosis. And in part 3, you will have all the other syndromic ichthyosis. So this is part 3 and this will be part 2. Without much further ado, we will start this lecture from the part 1 ichthyosis. So let's go move forward. Okay, so in the last slide, I tried to make sense of the classification of ichthyosis. And if you remember those classification, it will be easier for you to understand. And you will know that this particular disorder is actually an autosomal recessive congenital ichthyosis. And this particular disorder is X-linked ichthyosis. Okay, so it will make understanding this ichthyosiform disorders a bit easier. Okay, if we know the basic pathology, all you have to remember is what gene is mutated in each ichthyosis and what is the function of that gene. If you know that, then everything else will make sense. Okay, so with that, without much further ado, let's start. We'll start with the first part of the lecture, which includes common ichthyosis and autosomal recessive congenital ichthyosis. The segment A is common ichthyosis. Now, common ichthyosis have two ichthyosis, Ichthyosis vulgaris and X-linked recessive ichthyosis, or actually the new term is recessive X-linked ichthyosis. Okay, so let's move forward. We'll start first with Ichthyosis vulgaris. Ichthyosis vulgaris is also known as Ichthyosis simplex or Ichthyosis nacre. Now, nacre is a term which comes from mother of pearl. It's like a shell or a scale in on the inside wall of the oysters in which pearls are formed. Okay, so you can have a good quiz question out of this. That nacre is another name for it. So it's another name for Ichthyosis vulgaris. Now, initially it was considered as an autosomal dominant form, but this is now considered as autosomal semi-dominant. We'll get to it what it may actually means. Okay, autosomal semi-dominant. It is the commonest form. The vulgaris means common. So psoriasis vulgaris, verruca vulgaris, lupus vulgaris, ichthyosis vulgaris. These are all terms which means common. So it's the commonest form of ichthyosis. Now it has mild generalized scaling. Let's move forward. Okay, very generalized scaling, mild scaling. The mutation is in the filaggrin gene. And if you've gone through the last week's lecture, you know that profilaggrin gets converted into filaggrin. And this is one of the most important protein in keratinization. And it is one of the most important constituent of keratohyalin granules. Just remember that. And this keratohyalin granules are majorly seen at the level of stratum granulosum. So is it making any sense? You have filaggrin inside keratohyalin granules, and these keratohyalin granules are majorly part of the granules that we see inside the keratinocytes when they are at the level of stratum granulosum. That is why that layer is called as granulosum because here the cells have a lot of granules. Clear? Now remember in profilaggrin gene, there are multiple copies of filaggrin molecules or filaggrin genes. So each of this circle will lead to formation of one filaggrin. So when this entire gene gets translated, even a single process of translation leads to multiple copies of filaggrin. Clear? So that is the nature's way of forming a lot of filaggrin with just one gene. We're clear about it. If a mutation happens in filaggrin gene and one of the gene is mutated, the patient will have only hyperlinear palms and dry skin. Okay, so whenever you see a patient with hyperlinear palms or dry skin, or in fact even keratosis pilaris, Just remember that the patient has one gene mutated for filaggrin. But as I've said that this is an autosomal dominant disease. That means both genes have to be mutated for overt clinical scaling. Okay, we all know that there are two genes, X and X, or capital A. Let's use capital A and small a. Let me try to explain autosomal semi-dominant inheritance. A, A. Okay, for Ichthyosis vulgaris to occur, you need to have both of the genes mutated. Clear? Both genes have to be mutated because it's a dominant disorder. But if one gene is mutated and the other is not mutated, so in normal autosomal dominant disorder, this will not lead to a disease and this will lead to a disease. Okay? If both genes are mutated, then you will have that disease. Clear? And you will have a severe disease. But if none of these genes are mutated, let me just remove this. If none of genes are mutated, you will have normal baby. Clear? So for autosomal dominant inheritance, if one gene gets mutated, you will have 100% penetration of that disease. That's how autosomal diseases work. Autosomal dominant diseases work that if one gene is mutated, you will have that dominant trait and you will have the disease. Clear? But in autosomal semi-dominant, if one gene is mutated, you will have only light clinical manifestation like hyperlinear palms and dry skin. But for the overt clinical scaling, for the whole skin to show all the effects of ichthyosis, both the genes have to be mutated. So remember, both gene gives rise to overt clinical scaling, while one gene mutation will give rise to features like KPs, hyperlinear palms, and dry skin only, not overt ichthyosis. And this particular inheritance makes Ichthyosis vulgaris an autosomal semi-dominant. Clear? If any confusion in autosomal semi-dominant, just mention in the comments below with the timestamp that I'm not able to understand this thing, and we'll have a good discussion there. Let's move forward. So filaggrin gene mutation is a common gene mutation. It is seen in about 10% in general population. So general population, 10% of us have filaggrin mutation. In fact, I have a filaggrin mutation. I have hyperlinear palms. I have dry skin. I have atopic dermatitis. So it's quite common in the general population. We have talked about autosomal semi-dominant trait. Now, when filaggrin is mutated, filaggrin performs a very important function in our skin. And when the protein is mutated, you have impaired epidermal barrier, you have increased transepidermal water loss, you have decreased natural moisturizing substances, which are the histidine and rich amino acids, which are formed by the degradation of filaggrin. Okay, so if filaggrin is not present, the degradation products will also be not present. Clear? And if degradation products are not present, you will not have natural moisturizing substances and the skin will be extremely dry. Additional features of filaggrin mutations are atopic dermatitis, allergic rhinitis, asthma, food allergies, hand eczema, nickel sensitization, and eczema herpeticum. So whenever you see hyperlinear palms in your patients, consider a mutation of filaggrin in the back of your mind. Okay, let's move forward. So Ichthyosiform vulgaris, the clinical features are not present at birth, but about 40% of the patients will develop features by third month. So it gradually develops with time. The scaling decreases in summer because of humidity and seasonal variation. Now, filaggrin is not there. The skin is not able to moisturize properly. So, in seasons where moisturization is not a problem, that means in summers, the clinical features might be less. But in winters, when the skin naturally gets dry up, in filaggrin mutation, you will have excess drying of skin and there will be increase in symptoms. Clear? There are light gray scales over the extensors. This you have to remember that Ichthyosis vulgaris, the extensors are involved and flexures are spared. Now remember in atopic dermatitis, You can have flexures involvement, but extensors might be spared. But in Ichthyosis vulgaris, the flexures are spared. That means the cubital fossa, the popliteal fossa are spared. Clear? The scales have turned up edges. That means if this is the skin surface and this is the scale, the edges of the scale are turned up. That means they are a bit lifted. And this turned up edges give rise to roughness of the skin. And it is also known as the stapled appearance of scales. Stapled appearance of scales. That means as if like somebody has put a stapler at the center to stick the scales to the skin and the edges are up. Okay. Other features like hyperlinear palms, hypohidrosis, keratosis, pilaris, atopic eczema are linked. Now, if a patient has atopic eczema, it has about 10 to 15% of chances to develop ichthyosis vulgaris. Okay. And a patient of ichthyosis vulgaris has about 25 to 50% to develop atopic eczema. Clear? Because the underlying mutation is same. The mutation is there in the filaggrin gene. Let's move forward. Now look at this. I've taken this clinical picture from Bolognia, and some of you might be seeing it in black and white because of general YouTube guidelines, while some of you will be seeing it in color. So let's see the fine white scaling that you this look at all the skin. It's covered with fine white powdery like scales. And if you look at the size of the scales, they are smaller. They are brownish, gray. Okay, these are the color brown, gray, small scales, lighter in color, fine scales. Okay, so these are the adjectives that you will hear in a description of Ichthyosis vulgaris. Let's move forward. So in Bolognia, 5th edition, page 903, you will see a picture of hyperlinear palms, and that is because of filaggrin mutation. And look at this fine white scaling. And if you look closely, I request you to open the book at this page and see this image very closely. You will see the stuck up edges of the scale. Okay. You have the skin surface and you will have the edges stuck up. The edges are up. Now, on histopathology, one thing to understand is you don't have filaggrin. And filaggrin is seen in keratohyalin granules. So keratohyalin granules will also be not there. So if those granules are not there, you will not be able to see the granular layer because that's what we see in normal granular layer. We see keratinocytes which have granules. So in the granular layer, if you remember your previous histology, if you don't just go back and see the lecture on histopathology of of epidermis, and you will see that granular layer is composed of these basophilic granules here. A lot of cornocytes. In fact, they are stacked up like this. Okay, and all of them have these granules inside. That is how you recognize stratum granulosum. And if these granules are absent, okay, if these granules are absent, you will not be able to see the granular layer. And that is why in Ichthyosis vulgaris, because of filaggrin mutation, you don't have a granular layer. In fact, you have decreased or absent granular layer. In 50% of cases, there is no granular layer. Remember this is very important. In immunohistochemistry, you will see decrease or absent filaggrin signal. You will have scarce, crumbly keratohyalin granules. Why? Because filaggrin is not there. And the defect correlates with the extent of filaggrin mutation. So look at this picture that I've taken from Bolognia, page 903, 5th edition. You will see orthohyperkeratosis. Let me just change color. You will have orthohyperparakeratosis and you will have absence of granular layer. See, in granular layer, you will see cells like this, like this. And they will be filled, they will be forming a layer, the stratum granulosum. But here you can see that it is not here. It is not seen. The stratum granulosum is not here. And that is what we mean by absent granular layer or a weak or deficient granular layer, which is seen in Ichthyosis vulgaris. Let's move forward. Now, the management is pretty much easy. I'll make a separate lecture on management of all types of ichthyosis. So we'll discuss that in detail there. But you have to start with ointments that hydrate the stratum corneum. You should use glycerol containing creams. Urea less than 10% or lactic acid less than 12% are good cream to add. They are at this concentration keratopathic agents. Not keratopathic, I'm so sorry. The term that is used is keratoplastic agents. In higher concentration, they are keratolytic, but at this concentration, they are keratoplastic. Okay, so you have to take a bath and apply ointment. Topical protein substitution therapy is a newer way in which you just apply a ointment in which different proteins have been mixed, and these proteins go inside the skin, inside the cell, and replenish the mutated filaggrin protein. But that is much of a academic and theoretical interest. Now, the second common ichthyosis are the recessive X-linked ichthyosis group. Okay. Now, these are autosomal recessive in inheritance, as the name suggests, and the European population prevalence is about 1 is to 1500 to 1 is to 9500. The main mutation lies in the steroid sulfatase gene. Okay. So, there's deficiency of steroid sulfatase enzyme. So that is the additional name for X-linked recessive ichthyosis. That is steroid sulfatase deficiency ichthyosis. Another name is placental sulfatase deficiency ichthyosis or X-linked ichthyosis or aryl sulfatase C deficiency ichthyosis. But you don't have to remember anything. Just make sure you remember that the deficiency or the mutation lies in the steroid sulfatase gene. Steroid sulfatase gene. Now here also you have mild generalized scaling. Now when we say mild, we don't mean that the scales are not thicker. For example, in XLI, the scales are thicker, but it is just that only the scale has an issue. There's no underlying problem of other layers as much because we'll come to disorders like Harlequin ichthyosis or bathing suit ichthyosis, where you will see that the scaling can be a bit more severe. Let's move forward. Now, the pathology lies in the STS gene. STS gene is steroid sulfate. And if the gene is mutated, that means in 90% of the cases, it's because of deletion of the gene. And there is deficiency of the enzyme steroid sulfatase. Now, steroid sulfatase is required to convert cholesterol sulfate to proper cholesterol. And when the enzyme is not present, you will have accumulation of cholesterol sulfate. Now, this accumulation inhibits proteases like kallikrein 5 and 7. And these proteases, kallikrein 5 and 7, are required for normal, I'll just write it here, required for normal degradation of corneocytes. So when these proteases are not there, the corneocytes are not degraded, and that leads to retention hyperkeratosis. Remember, in retention hyperkeratosis, the cells are not able to leave the skin layers. And why they're not able to leave? Because the corneodesmosomes are not degraded. Now let's do a simple revision first. You have corneocytes stacked like this normally, and they are linked together by desmosomes. All cells are linked together by desmosomes. But in corneocytes, these are a bit specific and they have a different name which are known as corneodesmosomes. Now, when these corneodesmosomes are degraded, the cells eventually lose their attachment and they fall off. That is the normal kinetics of the skin. Clear? Now, when the normal kinetic skin is affected, that means the corneodesmosomes are not able to get removed. The cells will not be able to leave the skin and they will be retained. And that leads to retention hyperkeratosis. Okay. So here the problem doesn't lie in the granular layer. So you will see granular layer in the biopsy. Now, the transepidermal water loss is increased, but the pH is somewhat normal. If the mutation is in the STS gene, then you have XLRI. If you have the mutation extending to the surrounding regions of the gene, you will have syndromic X-linked ichthyosis. Syndromes like Kalman syndrome, X-linked chondrodysplasia punctata, brain abnormalities, unilateral polymicrogyria, disorders like retinitis pigmentosa. Now, these kind of disorders are also linked with X-linked diseases, sorry, X-linked ichthyosis. Let's move forward. Now, this is the pathophysiology of X-linked ichthyosis. You have cholesterol sulfate, and this is the steroid sulfatase, the enzyme that we are talking about at the level of stratum corneum. If this enzyme is not there or mutated, like we have in XLRI, you have accumulation of cholesterol sulfate. Okay. Now, this accumulation of cholesterol sulfate leads to PKC activity increase, transcription regulation, and protease inhibition. Now, protease is required for proper desquamation. If this is inhibited, desquamation will not occur. Okay. So, since it is an X-linked disorders, males are more severely affected. A lot females might have an effect because of Lyon hypothesis, but males are the ones which are affected. At birth, about 15 to 20% of the cases can be seen. The scaling can be seen at birth. Remember, in Ichthyoses vulgaris, the birth is normal, and by third month, about 40% develop the scales. Now, here the scales are large, thick, dark brown to yellow brown scales over trunk and extremities and neck, and the neck has a dirty look. The same dirty look that you also see in atopic dermatitis or the dirty neck of atopy, but the dirty look is because of the retention of the scales, the thickening of the skin with the retention of the scales. 30% of cases can have light gray scaling, which are similar to what we see in Ichthysis vulgaris. Okay, so in 30% of the cases, the scales can be light gray, similar to what we see in Ichthysis vulgaris. The antecubital popliteal folds in palms and soles are spared, which are the same as Ichthysis vulgaris. If there is a concomitant filaggrin mutation that leads to a severe disease. We know that steroid sulfatase deficiency is there in XLRI, and this steroid sulfatase is also present in the placenta. Okay, and if this gene is mutated and it's not working properly in the placenta, this leads to decreased estrogen conversion. And because of decreased estrogen conversion, which is another function of steroid sulfatase, there is insufficient cervical dilatation. And this can lead to prolonged delivery or C-sec or even forceps during delivery. So whenever you see a patient who you suspect to have XLI, it's a good idea to ask the parents of the child that was there any prolonged labor or the need for C-section. Why? Because in the absence of steroid sulfatase, you will have decreased estrogen conversion and leading to insufficient cervical dilatation, leading to prolonged delivery or use of forceps. Let's move forward. Now look at these clinical photos that I've taken from Rooks 10th edition, 63.6 page, and you can easily see that here the scales are darker. Okay, they're darker, they're larger than what we see in Ichthysis vulgaris. Look, the large scales. They are more generalized, more involvement of the body. Now, the color of the scales are darker, and that is why XLRI is also known as Ichthyosis nigra. Nigra means black. Okay, so that is why that is another name for XLRI, Ichthyosis nigra. Let's move forward. Now look at this magnified view, and you can find that the scales are larger, geometric, darker in color, and thicker. So if you see larger scales predominantly over the shins, increase during winters, thicker, darker scales, think of XLRI. If you see smaller, light gray, brownish, light brownish scales, smaller in size, easily brushed off, fine, think of Ichthyosis vulgaris. Let's move forward. Other clinical features include corneal opacity, but this corneal opacity does not affect vision. This corneal opacity is seen in about 10 to 50% of the cases. There's 20 times increased chances of cryptorchidism. Okay. And this increases the risk of testicular carcinomas in patients who have XLI. 40% of cases can have ADHD, 25% can have autism, and epilepsy and itching are also a feature of XLI. Now remember I told you in pathophysiology that if you have mutations in the STS gene, if STS gene is mutated, you have XLI. But if the mutation extends to the adjacent areas, you have syndromic XLI. Why? Because all the genes are located side by side, and if you have problems in the genes encoding for testicular migration, you have cryptorchidism, you have increased risk of testicular cancer, you have neuronal problems like ADHD and autism, you have eye, because I've told you that retinitis pigmentosa is also associated with this mutation or adjacent area to SCS. So you have eye involvement like corneal opacity in 10 to 50% of the cases. So these all genes that encode for specific proteins are located together, and the mutation extends to the other areas, you have syndromic involvement of other organ system. But if it is restricted to STS gene, you have XLI. Okay, let's move forward. The investigation includes pedigree analysis, which is the most important in any genetic disorders. Biopsy will show orthohyperkeratosis with a well-maintained and thickened stratum corneum. Now, this is important because we know that in Ichthyosiform vulgaris, the stratum granulosa, sorry, I said stratum corneum, thickened stratum granulosa. In Ichthyosiform vulgaris, stratum granulosum is absent. So this is the this is the part that you can differentiate easily on biopsy. If granulosum layer is there, it's XLI. There's marked follicular plugging in about 30% of the cases, and the corneodesmosomes are persistent in biopsies. You can also do steroid sulfatase levels in fibroblasts and plasma, they will be decreased. You can do genomic studies like FISH or comparative microarray analysis for to see any mutations. You can see lipoprotein electrophoresis for increased mobility of beta lipoproteins, or plasma levels for cholesterol sulfate for research purposes. And these levels will be increased. So remember, pedigree analysis is the most important form of investigation, followed by a biopsy if you still have doubts. Let's move forward. The management is same as Ichthyosiform vulgaris. You use moisturizers, glycerol-containing creams. Low-dose systemic steroids can help. Sorry, systemic retinoids can help in severity and exacerbation. So here you have a role of systemic retinoids. Okay, so because the problem lies in the retention hyperkeratosis, you have to give something that increases the proliferation of corneocytes, and that is what retinoids do. So low dose systemic retinoids are an important modality to treat, especially during winters where the scaling can be severe and excessive. Let's move forward. So with that, we have finished the first segment of this lecture. The second segment includes autosomal recessive congenital ichthyosis, or ARCI. Now, ARCI is an umbrella term. What do we mean by that? That means all the ichthyosiform disorders which are autosomal recessive are grouped together under the umbrella of ARCI. Okay, and these disorders will have mutation in different proteins, not a single protein, but they present as autosomal recessive congenital ichthyosis. That's why they'll be discussed together. And these includes your disorders like lamellar ichthyosis or Harlequin ichthyosis or bathing suit ichthyosis. Clear? So one by one, we'll discuss ARCI and all the subtypes. Okay. And let's start our discussion first with the treatment contains ointments, glycerol containing creams, urea lactate creams, and frequent ointment application. The general modalities or general features of ARCI. Now, ARCI is also known as Ichthyosis congenita. It's an umbrella term which includes all non-syndromic autosomal recessive forms of ichthyosis. Remember non-syndromic. If it is syndromic, it's a separate group altogether. ARCI includes ichthyosis like Harlequin ichthyosis, bathing suit ichthyosis, lamellar ichthyosis, congenital ichthyosiform Erythroderma, self-improving congenital ichthyosis, and Collodion Baby. So let's move forward and discuss each one of them in detail. The pathophysiology is diverse in ARCI. Why ARCI is diverse? Because it's an umbrella term. It has a lot of different kind of disorders, and every disorder will have different mutations. So the total mutations seen in ARCI are very not haphazard, but multiple. So there are multiple mutations. For example, ABCA12, which is a protein which is mutated in lamellar ichthyosis or CIE. Biosynthesis of lipids are mutated. For example, CERS3 gene is mutated, and that is also seen in lamellar ichthyosis. Genes for fatty acid metabolism or cornified envelope assembly, like transglutaminases, or temperature-sensitive mutations in transglutaminase 1 is seen in bathing suit ichthyosis. Just remember that in disorders which are discussed under the gambit of ARCI, all the disorders can have multiple mutations in multiple different genes. So there's no one gene affected. For example, in Ichthysis vulgaris, you had the mutation in filaggrin gene. In XLRI, you had mutation in the steroid sulfatase gene. But in ARCI, multiple genes can have mutations. Okay. In fact, in 10 to 20% of the cases, no known genes are found. Let's move forward. So let's start discussion with the first disorder, Harlequin Ichthyosis. Now, Harlequin, the term has there are multiple etymologies of this term where the term has come from, but remember that Harlequin just means a demon. So one of the demon in older plays was called as Harlequin. So since the baby looks a bit scary because of the appearance, it was termed as Harlequin Ichthyosis. It's the most devastating ARCI. The incidence is about 1 in 2 million. It's 44% lethality rate, and this is I'm quoting Rooks 10th edition. Okay, so 44% lethality. The neonates are encased in an armor-like skin. So an armor-like skin in which you have fissures in between, and this skin, this scales, this armor restricts movement. So much so that you can have movement disorders, breathing difficulties. There are bilateral ectropion and eclabium. Eclabium is outward turning of the lips. And the retrooral folds, that means the fold behind the ear, is absent. Why? Because the pinna is stuck to the skull, okay, stuck to the head. So there's no fold there. Now, this kind of restricted movements can even lead to auto amputation in about 10% of the cases because the hard armor is not allowing the body to grow. It is restricting its growth, and that can lead to auto amputation in about 10% of the cases. There are increased skin and lung infections, so much so that lung infection can lead to alveolar collapse. There's respiratory problems, and that is a major cause of mortality in neonates. So that is an important question to be asked in Viva exams. That the most common, sorry, the major cause of mortality in neonates in Harlequin ichthyosis is the respiratory problems. And if the infant manages to survive, there is stratum corneum thickening, marked Ichthyosiform erythroderma, persistent ectropion, and wasting. The vitamin D deficiency can also lead to rickets and osteomalacia. Let's move forward. Now, in investigation, you just get a biopsy done. You will see enormous thickening of the stratum corneum. Okay, there's parakeratosis, there is hypergranulosis, there's decreased non-polar lipids and proteases like kallikrein 5 and cathepsin D. We have discussed in ARCA that these kind of proteases are responsible for removal of corneodesmosome, and the mutation in these proteases leads to retention hyperkeratosis. And that is why a thick stratum corneum is formed, which does not allow the body to grow. If you do electron biopsy, you will have abnormal lamellar bodies, and there will be accumulation of lamellar bodies in between the cells, and this appearance is highly pathognomic for Harlequin ichthyosis. Okay, so remember there's a defect in lipid transportation, and that is why the lamellar bodies are not able to form properly. Now, what exactly are the function of the lamellar bodies or the Odland bodies? Go back to last week's lecture on keratinization and just go through it, and you will easily find where the problem is there. Let's move forward. Now look at this image that I've taken from Rooks 10th edition, page 63.9, and it shows an Harlequin baby at birth. So you can see that the fist or the hands are encased in a thick armor, like there is fissuring in between, there is ectropion, there is eclabium, and that is at birth. And the treatment is that you manage symptomatically and you start low dose retinoids. So after 6 weeks of retinoids, you can see that there is good amount of shedding of those thick armor like scales. And at 6 months on retinoid, the baby is somewhat near normalcy. Okay. So this is the most devastating type of ARCI, and it has implications on life, and the treatment has to be initiated fast. Let's move forward. Let's discuss the second segment, the Collodion baby. Now, the Collodion baby is by definition transient. It is seen in newborns, and most of the ARCI and syndromic congenital ichthyosis present with Collodion baby except Harlequin. Okay, so in Harlequin, you have a thick armor-like casing, while the collodion membrane is seen in all other forms of ARCI. I hope I made myself clear. Now, this is a shiny parchment-like membrane that cracks within a few days after birth. In contrast, in Harlequin ichthyosis, you have thick armor-like plates. So this is thicker, while collodion membrane is thinner. So there's one more difference. The membrane peels off within 4 weeks and leaves behind normal skin. You can have ectopia and everted lips, which improves with age. 80% of the cases after peeling of the collodion membrane will develop some form of ARCI. This could be bathing suit ichthyosis or lamellar ichthyosis or congenital ichthyosiform erythroderma. While about 10 to 20% of them can have self-healing or self-improving congenital ichthyosis. Okay, so 80% will have other forms of ARCI like lamellar, CIE or bathing suit ichthyosis, while 20% will have self-healing or self-improving ichthyosis. So about 10 to 20% will improve by age, while the rest will form another different type of ARCI. Let's move forward. So look at this shiny parchment-like collodion membrane. It is totally different from what you see in Harlequin ichthyosis. Those thicker plates are not there. You have mild eclabium, ectropium. And after birth, it has now changed to self-improving congenital ichthyosis, in which you have mild scaling present. Otherwise, the skin is somewhat normal after peeling of the collodion membrane. Let's move forward. Now, the third segment is lamellar ichthyosis or congenital ichthyosiform erythroderma. Now, remember these are two parts of a same spectrum. So this is a spectrum. At one end you have LI, and other end you have congenital ichthyosiform erythroderma. In lamellar ichthyosis, you have the word lamella. Lamella means scales or plates. So here you have a lot of scaling and a little bit of erythema. While in CIE, the E stands for erythroderma. So you have more erythema in CIE and less scales. Clear? So lamellar ichthyosis have more scales, less erythema. CIE has more erythema, less scales. Clear? Now, lamellar ichthyosis, the term was given by Philip Ross. It has large plate-like dark brown hyperkeratosis over whole body. So these are plates, and because of plates, it is known as lamellar. So lamellar ichthyosis. There's mild palmoplantar keratosis, and because the plates don't allow the hair to grow, you have alopecia. In congenital ichthyosiform erythroderma, you have erythroderma, which is marked with fine scaling. So, can you understand that the scales are less in CIE, more of erythroderma? You have pronounced palmoplantar keratoderma, but alopecia is not there. So, that's an important differentiation between lamellar ichthyosis and CIE, that alopecia is not there. Ectropion eclabium can be there. The earlier name for CIE is non-bullous congenital ichthyosiform erythroderma, but now the name has changed. Now we call it as congenital ichthyosiform erythroderma. Let's move forward. So in the previous slide, we have discussed that lamellar ichthyosis means more of plate and scales in manifestation, while in congenital ichthyosiform erythroderma, you will have more of erythema or erythroderma or background redness. Okay. Now, there is a slight erythema in lamellar type, and there are slight scaling in the CIA type. But you have to know that what kind of clinical feature will be more predominant in any other spectrum. Now, understand that there are a few features also. For example, in lamellar ichthyosis, you will have alopecia. While in erythrodermic congenital ichthyosiform disorders, you will not have alopecia. You will have more of PPK or palmoplantar keratosis in CIE and less PPK in lamellar ichthyosis. So let's come to the pathomechanism in lamellar ichthyosis. The most common mutation is in the transglutaminase 1, which is about 32% of the cases. Now, as I've said previously, that ARCI has multiple mutations because a lot of different kind of proteins are affected. For example, in 16% of the cases, there's mutation in the NIPAL4 gene. NIPAL4 gene is also, it encodes a protein known as ichthyine, which is the magnesium transfer protein for lamellar body formation. So NIPAL4 will have mutation in the formation of lamellar bodies. 12% of cases have mutation in LOX12B, which is a part of hypoxylin pathway, and this pathway is also responsible for lipid transport in the lamellar bodies. The same is about 8% in CYP4F22, which encodes for cytochrome enzyme in lipooxygenase system. This is also required for lamellar body formation. And 5% cases have mutations in LOX-E3, which is a part of arachidonate epidermal lipooxygenases. And all of these mutations are needed for formation of proper lamellar bodies. So we can understand with all these aspects that even after having different kind of mutations, the problem lies in the mutated form of lamellar bodies, and the lamellar bodies are not able to properly carry out their function, and that leads to the spectrum of lamellar ichthyosis or congenital ichthyosiform erythroderma. So you can easily understand that lamellar ichthyosis have problem in the lamellar body. So you can remember it by this. There are other genes involved like SERS, S3, lipin, SDR9C7, SULT2B1P, and PLA1, but you need not remember it. Just remember that multiple different kind of genes can be involved in this spectrum. Now, this picture I've taken from Fitzpatrick 9th edition, page 789, and it tells you about the spectrum of transglutaminase 1 mutation. Each of these patients have transglutaminase 1 mutation, but you can see the scaling is milder here. And as we move and go towards this end, we have severe scaling. We have severe lamellar plates. So this is more towards lamellar ichthyosis, while this is more towards congenital ichthyosiform erythroderma. Okay, so we can see that the mutation is still in one protein, transglutaminase 1, but it can manifest as a variable disorder, variable thickness of scales, variable involvement of the body. So you can understand the concept that multiple proteins can be involved in the spectrum and with multiple intensity also. Let's move on. So this is lamellar ichthyosis. You can see thick plate-like dark scales and this background erythema. And this background erythema is what differentiates the scales from X-linked ichthyosiform disorder or X-linked ichthyosis. In XLI, you don't have background erythema, isn't it? But in lamellar ichthyosis, background erythema is present, at least in the initial stages. So this erythema can be seen. There's flexural involvement in the form of flexural scales. Can you see this scale involvement? This I've taken from Bolognia, page 910, 5th edition. And we have ectropion in the baby because, as I've said, that all kinds of ARCI except Harlequin Ichthyosis starts as collodion membrane, and collodion membrane has a feature of ectropion. Okay, so these are the pictures to show lamellar ichthyosis. Let's move forward. And this is to show congenital ichthyosiform erythroderma, and you can appreciate now that the scales are not the major features. The background erythema is what is majorly present. Okay, so the background erythema is important and is covered with fine white scales. Okay, so fine white scales. Clear? So now you can easily understand the difference between congenital ichthyosiform erythroderma and lamellar ichthyosis. More plates to more erythema, and they are part of the one spectrum. The most common mutation is in transglutaminase 1. Let's move forward. So this is to compare the lamellar ichthyosis and congenital ichthyosiform erythroderma to show that lamellar ichthyosis in initial stages can have erythema. So it's not like erythema is absent, but here the mutation might be in a different protein, different gene, and that is why you can have a component of erythema, and you can have insufficient scaling in congenital ichthyosiform erythroderma also. Just remember that during the initial stages of the disease, you will have more erythema. You will have more scaling in lamellar ichthyosis and more erythema in CIE. And as the disease progresses, the baby will eventually fall into one of the other categories, either lamellar ichthyosis or congenital ichthyosiform erythroderma. Okay, let's move on. So, what other investigations would you go for? In transglutaminase 1 deficiency, you can sequence the gene and find out what is the activity of transglutaminase 1. Of course, it would be reduced in lamellar ichthyosis. If you do electron biopsy, you see cholesterol clefts in stratum corneum, and this is a very important feature. It's a striking feature in ARCI, in lamellar ichthyosis, in congenital ichthyosiform erythroderma, in which you have malformed lamellar bodies in between the cells, leading to formation of cholesterol clefts. In NIPL4 mutations, you have abnormal lamellar bodies and elongated membranes in stratum granulosum. In lipooxygenase deficiency, and these are the genes which are involved, you can only find the mutations in these genes by using techniques like direct sequencing or whole exome sequencing. In other words, what I'm trying to say is that the investigations are not at all that important because for research purposes, all you can do all these kind of investigations. You can do whole exome sequencing, genetic analysis, and everything else. But most of the time, the diagnosis is based on the clinical features and pedigree analysis. So these two are the most important factors that you have to keep in mind. Let's move forward. Now, the fourth spectrum of disorder is bathing suit ichthyosis. So it was found in South African Bantu tribe of Nguni ethnic group, and this is in Africa. The baby starts with a colloidal membrane at birth, and gradually, as the baby ages, it develops a lamellar type of ichthyosis. But this ichthyosis spares extremities and face. So you can see this diagram that the central part of the body is involved. Okay, as if there's a bathing suit distribution, as if the child has worn a bathing suit. So all the areas which are essentially covered by a bathing suit or a swimming costume, that area is affected. Okay, it arises because of a missense mutation in transglutaminase 1, leading to a temperature sensitive transglutaminase 1. That means this enzyme will get activated now at higher temperature. Okay, and if the child is moving out, and remember this has been described in Africa, which is an equatorial area, you will have higher temperature exposure or sun exposure over the exposed areas. Okay, and then the exposed areas, the transglutaminase 1 enzyme will get activated because of higher temperature and will function normally. But the areas covered by clothes, the TG1 is not activated and does not function properly, leading to ichthyosiform scales in a bathing suit distribution. Now, some patients may heal with age. And we remember that transglutaminase 1 is essentially required for the attachment of proteins like involucrin, envoplakin, periplakin while forming the cornified envelope. So if that protein is mutated, you will have improper formation of cornified envelope. So go back to last week's lecture on keratinization and you will easily understand what are the functions of transglutaminase 1. The clinical features include Collodion Baby at birth, and as the baby ages, large dark grey brownish scales that affects the trunk and the scalp, but majorly the covered areas. The palm and soles are dry and mildly hyperkeratotic. The warmer areas show scaling which worsens in summer and improves in winters, and there can be hypohidrosis, especially of the external auditory meatus. So there can be hyperkeratosis over the ear. So ear canal, the external ear canal can show hyperkeratosis. In fact, so much hyperkeratosis can happen that it might require removal of that hyperkeratotic scales. Otherwise, the child has hearing difficulties. Those scales also interfere with sweat production, and that leads to hypohidrosis. So remember, in bathing suit ichthyosis, you have hyperkeratosis leading to decreased sweat, and it can even block external auditory meatus. Okay, let's move forward. Yeah. So this image I've taken from Rooks, and you can see that the scales are involved in a bathing suit and flexural distribution. So here it is distributed in a like a person has wear a vest or a swimming costume. So you can see the involvement of the covered areas is more. Let's move forward. So in bathing suit ichthyosis, if you take a biopsy or do any kind of analysis on an unaffected skin, it comes out to be normal. So you have to take a biopsy or an sample from the involved skin. In the involved skin, you will find lower transglutaminase 1 activity. Okay, and that activity will be less in the involved area. On biopsy, you will see massively thickened stratum corneum with multiple cholesterol clips. So these are the features that you will see in involved skin biopsy in a patient of bathing suit ichthyosis. Let's move forward. Okay, so with that, I'll finish. It's already crossing 1 hour, so I'll finish the part one of ichthyosis, and we have covered all the major ichthyosiform disorders that is usually asked in exams, and you should know as resident of dermatology. We have covered Ichthyoses vulgaris, XLRI, ARCI. Subtypes include Harlequin Ichthyosis, Lamellar Ichthyosis, Congenital Ichthyosiform Erythroderma, and bathing suit ichthyosis. Okay, so all the major ichthyosiform disorders have been covered in detail. If you have gone through this video, you don't require to read it from Rooks. Rooks has what the problem that Rooks has is that it has explained ichthyosis in a linear format, so you are not able to understand intuitively. All you need to remember is that what gene is mutated and what is the function of that gene. If you know that, and if you have gone through my lecture of last week's keratinization, you will understand where the problem is and how it is translating into different clinical features. Okay, I hope that till now the ichthyosiform disorders have been clearer now, and you may just have to go through this video more than once to understand how we are divided. Remember the classification slide that I shown, that is very important. If you look at that classification slide, you'll be easily able to understand and easily able to segregate these disorders into uh, different groups, and then you'll be able to understand them better. Then it will start to make sense. Okay. Now again, I'll remind you about the NAMSCON Mediquiz quiz that is going to be held on 27th October. The prelims is on 27th October next week, and it's an online quiz on prelims, and the registration is free but mandatory. You can scan the QR code and just start with the prelims, which is on 27th October, and six of the finalists will be called for the final round, and if you know about this quiz from the previous iterations, the cash prizes are extremely lucrative. Okay, so make sure that you scan this QR code and register. Otherwise, I'll give you the link to register in the description. Just go to the description and click and fill the Google form. And I'll be making quizzes for this particular quiz. And next week, let's see you in the prelims of this quiz. So with that, we'll finish the part one of ichthyosiform disorders. I've tried to make it simpler. I've received multiple messages that this is one of the worst chapters in Rooks, and it becomes difficult for people to go through. And I totally agree with it, because by the time I was reading it during my residency, and in fact reading it again now, it was difficult to make sense of what exactly is happening. Every disorder looked same. So I focus more on the differentiating aspects so that you can understand and delineate each disorder separately. So without much further ado, any comments, suggestions, and queries you can put in the comment section and put in timestamp so that I know what part of video you're talking about. You can in fact email me, but I prefer if you put in the comment section so that other people can see the same doubt and learn from it. So without much further ado, I will stop the part one. We'll meet next week with the part two, keratinopathic ichthyosis and epidermolytic ichthyosis. Till then, adios and bye bye.